My name is Jared Weiss. I'm a thoracic and head and neck clinician and clinical investigator and section chief of a joint thoracic head and neck section at UNC's Lineberger Comprehensive Cancer Center. And I've had the privilege of being a sub-investigator on the 1100 study. So 1100 was actually a study of three populations: patients with head and neck cancer that was inoperable, local, regional, or recurrent metastatic with tumor in a previously irradiated field. And that data has been previously reported. There was another cohort for liver mets that were not previously irradiated and patient indicated for PD-1. And what we saw data on at ELCC was patients with that has metastasized or spread to the lung from other sites. That site could be lung or it could be something else. The tumor spot itself had to not be previously radiated, and the patient needed to be indicated to receive anti-PD-1, whether they had seen it before or not. It needed to be a good idea that the clinician liked already. We've already shown data before on abscopal responses, and maybe I should take away the air quotes. Abscopal is the idea that you radiate one spot and you get a response in another spot. And the reason for the air quotes is that historically, it's been 10 to 20 times more prevalent from radiation oncologists on the podium than anything that you ever see in clinic. And perhaps to me, the most exciting thing we've seen thus far in the 1100 data was data that Dr. Colette Chen has presented before showing actual abscopal responses. So she's shown before that head and neck data that had a 28% response rate in immune checkpoint inhibitor resistant patients and 48% in those who were naive, with an impressive 32-month survival in resistant patients. So now we come fast forward to ELCC. And some of the main findings here were about safety and feasibility. So we talk often in the lung community about difficulty obtaining tissue. The most common place for this conversation is patients with actionable genomic alterations. And so perhaps the most important finding here was that it was very feasible to do the injections. Patients mostly got the amount of product that was meant to be put into each of the lung lesions and as many lesions as were indicated. Next, when you look at the complications from the injection and the product, they were limited. There were only a few high-grade events in the whole study. Just a handful that were related at all. So it was feasible. It had acceptable toxicity. Not much to make of the PD-1 toxicity, as you would expect, because this was given to patients, many of whom were already tolerating PD-1 and were all indicated to get it. So combining all of this, there was about a 10% high-grade toxicity rate with no clear pattern of concern to it. And so, if you look, in addition to the feasibility, there was a very nice response rate here. It's heterogeneity in patients here, right? So don't take it to compare to anything too much. But if you look at the 8 immune checkpoint inhibitor naive patients, there were 2 complete responses, 2 partial responses. In the resistant patients, there were 19 of those. There were 5 partial responses. And so it seems to be an active strategy. So I think there's heterogeneity of strategies that this can be incorporated into as future directions. There's an ongoing phase 3 head and neck cancer study that could be indication resulting. As far as lung cancer goes, we await data on a phase 2 of inoperable stage 3 disease and a phase 1 of inoperable recurrent disease. Other studies are also ongoing or planned in other disease states. As I mentioned, the most advanced is the NanoRay 312 in elderly platinum-ineligible locally advanced head and neck cancer. It's a mouthful. That should complete in 2026. And I and others am excited to see future directions to build upon strategies like Pacific to see how this might integrate into the treatment of locally advanced unresectable stage 3 lung cancer. And we'll have to see if we get such studies. It's a little bit of a have your cake and eat it too strategy. Many patients come with a local control problem. and fear or a problem with distant control. Head and neck is classic, and that's probably why this started study there, or one of the reasons it started study there, where my recurrent patients come in three categories: local, regional only, but non-curable; distant only, or both. And for that first and last category, where I have both a local control problem, perhaps causing symptoms, right? We're talking a little bit about the lung, so maybe it's a central tumor compressing airways, causing cough, trouble breathing, compressing central vessels. Or maybe it's somewhere else in the body where it's causing pain. There's a study of liver mets in this study. Maybe it's causing anorexia and pain at that site. But in general, what attracted me as an investigator was this idea that I could have a novel, effective mechanism to treat that local control problem that's causing symptoms. Or in the case of oligometastatic disease, maybe that's it. It's an efficacy thing getting at the local control. But then for a cancer as metastatic as lung, also controlling distant disease, whether it's macrometastatic disease that you can see or micrometastatic disease that you fear. This can be applied anywhere that you have both of those, that you both have interest in local control vis-a-vis the essentially frying effect that you get, right? Every photon releases 9 electrons. You get this nice local amplification. You can treat tumors that have even been radiated before. And then you get this immune potentiation that is so, so valuable, right? To me, the PD-1 agents are like pizza. So I'm pizza obsessed. I'm a recovering New Yorker. You give me that first slice of pizza, I'm not satiated. I'm hungrier, right? I want that second slice even more. I know it's in front of me. That's what immunotherapy has been to me. It's shown me that we can cure stage 4 disease, and we do, right? We can't be afraid of this word cure. More than 10 years later from the phase 1 patients, some of them alive and thriving, right? We know we can cure stage 4 disease, but we do it for a pathetically small number of patients. And so strategies like this that can potentiate immunotherapy and try to raise that tail, bring that for a larger proportion of patients are really exciting to me. It means we're going to do better, right? If you look at promising studies like this and many others, it means we're going to do better. I think, if I reflect back on what cancer was like, say lung cancer in particular, when I started in this, it was really, really very depressing, to be frank about it, right? We didn't cure that many people. Even when we did surgery, we had huge recurrence rates, stage 3 even more huge, and the cure rate in stage 4 was pretty close to 0. You fast forward to the modern time when we have all these new TKIs, when we have new classes of drugs. It's really exciting to think that we can do better. All of these are exciting to me, but personally, I've invested most of my career in immunotherapy, as many others have. And I think the reason that I and others are so passionate about immunotherapy in clinic and in investigations is because we want to cure people, right? I'll take any reduction in suffering I can get. I'll take any extension of duration of life I can get for individual people. Of course we will. But when you cure someone, you buy them decades of quality life, not weeks or months. And that's what's really exciting to me about this product is that it is an immunotherapy potentiator in addition to that immediate relief of suffering from the local effect. And I'm hopeful that it's one of the exciting ways that we might raise that tail and bring cure to a greater number of patients.